I was shocked to discover that only 22% of Nigerian hospitals at that point where childbirths take place had clean running water and soap. That was when I realized that we are all at the mercy of the health system wherever we happen to be. It truly is a lottery. Whether a program starts with my experience or the experience of another woman I have met, if we can learn from the experience of one and we can then take that to scale, it's worth the effort.
Every pregnancy should be.
Every pregnancy should be attended. Every pregnancy should be wanted. Every pregnancy should be expected. And every pregnancy should be catered for.
Hi, everyone, and welcome to the Born Into podcast. I'm Isra, Chaker, the CEO of Every Pregnancy, and I am so happy you're here. Every week, we bring you stories about something that affects every single one of us, but is not talked about nearly enough: the health of moms. So we bring you stories of crisis, of hope, of courage, and facts from around the world to talk about how to be a mom, how to support a mom, and how to help a mom. Today, I'm especially honored to be speaking with someone whose leadership has transformed the way we think about maternal, newborn, and child health in Nigeria and across Africa. Nigeria is one of the most dangerous places in the world to give birth, with nearly 75,000 mothers dying each year. That's 1 in every 7 minutes. Zooming out, 70% of all maternal deaths take place in Africa. But our guest today, Her Excellency Toyin Saraki, is working to change that. Her Excellency is the founder and president of the Wellbeing Foundation Africa, a pioneering Nigerian NGO that delivers frontline care and advocates for reproductive, maternal, newborn, child, and adolescent health, gender equality, education, and socioeconomic empowerment. All of those factors are aligned with the UN Sustainable Development Goals, which she is an incredible champion of. We just had the privilege of sharing the stage with her at Goals House during the UN General Assembly here in New York, where she reminded us why maternal health must remain at the center of the global agenda. One thing that stood out to me is how incredible Her Excellency's presence is, and how everyone at every table that she's at is listening, but also looking for her at her guidance and her support for the work that she's leading. She is truly a pioneer and a trailblazer in every meaning of the word. Her Excellency Toyin, welcome, and thank you so much for being here today.
Thank you so much, Isra. It's an honor and a privilege to join you.
Thank you. Let's start off with how you're feeling today. It's the 4th day of Unga, 5th day maybe. It's a whirlwind out here in New York City.
You know, Unga this year has been incredible.
Yes.
I'm not really sure what atmosphere the rest of the world was expecting to come to Unga with. But I came with a sense of purpose, because at the point in the world where some people think, or may even be wanting to retreat because they think action is discretionary. You know, I just feel that childbirth is as old as time. Wow. And we need to continue to replenish the efforts. We need to reinvigorate. We need to be generating innovation. We need to be harnessing all the tools. So I actually came to Unga as a very practical optimist. There are certain things that I knew worked. There were certain gaps that I felt we needed to fill. And I came with a very open mind, and particularly on maternal health financing, I realized that we would have to find new ways to finance maternal health around the world sustainably, and to keep empowering women, even through self-care, to actually not be a beneficiary, to be a partner in their own health. So I don't even know what day of the week it is at the moment. I've been running from meeting to meeting, but every meeting has been worth it.
Today you were at a round table this morning that I listened to with Serena Williams and other entrepreneurs. Share a little bit more about that experience.
Well, that's amazing, because what brought me to that round table initially is water, sanitation, and hygiene. So I will go back to 2018 first as to why I carried water and sanitation, hygiene again as a main thrust of our programming. You know, we had been working for 20 years I started the foundation in 2004, largely from personal experience and from a point of frustration, actually. I just felt that I can't be the only one that knows where the solutions are. And let's just get the solutions to bear on every pregnancy and every birth. And we had made fairly modest progress as a country. When I started working to make childbirth safer and to guarantee that children could live till at least, survive and thrive, at least minimum till age 5, we were losing 1 in every 6 Nigerian women to a preventable death at that point. The same 3 causes. It's postpartum hemorrhage, sepsis, which is in maternal infection, and then after that it's birth complications. And in 15 years, we started to see modest gains. But if you count those gains, from 1 in 6 dying to 1 in 19 dying, if you count them in a smaller country, you'd probably clap yourself on the back and say, oh, great, I've gone from 1 in 6 to 1 in 19. But when you're working in a country as large as Nigeria, with a population as large as ours, the percentages make you feel there's still a lot more work to be done. And in 2018, I saw a piece of data. The part of the deaths that were being attributed to maternal sepsis, I wanted to dig deeper to know what was the cause of the maternal sepsis. And I was shocked to discover that only 22% of Nigerian hospitals at that point where childbirths take place had clean running water and soap.
Wow.
And of those, only 12% had the clean running water and soap in the delivery room. So I started to understand why, I think it was 2014 that when we were looking at the essential medicines lists, the midwives and nurses in Nigeria requested elbow-length gloves instead of the wrist-length gloves. And putting the 2 and 2 together, I realized that it was because they didn't have always clean running water and soap in the delivery room to wash their hands between deliveries. And when you think that hand washing started in the 16th century with Semmelweis, who noticed that there was no childbed fever in the wards being attended to by female attendants, but there were some terrible infections bouncing about in the male wards. And he was almost hounded out of the medical profession for saying that he thought women, observed water sanitation hygiene better. I took up water sanitation and hygiene again in healthcare facilities, in schools, and in communities, because I knew that all the gains we were making in making childbirth safer could be undone if infection was not prevented and controlled. So today was like a full circle, because I was sitting down at the launch of Catalyst, which is a new fund by social impact arm of Reckitt, and it's upturning the usual direction. Usually when you're doing a social impact investment, it's from the global north and it's coming into the global south. And we had run accelerator programs with them in Eunice Social Business before to find people who were innovating and to do that seed investment into their businesses. And I always said that all the winners from Nigeria were always innovation responding to need. So we always had a lot of water innovators. We had a lot of menstrual hygiene innovators. We didn't really have that many nutrition innovators at that time, but I'm sure we'll see some next year. And Serena Williams has been appointed the entrepreneur
That's incredible.
in residence of Reckitt. And I particularly think that's wonderful because she's a young woman who had recently delivered. Her first profession was as a sportswoman. Her second profession now is as an entrepreneur. And she shows that, as a woman of color, they say only 2% of businesses are actually started by women. And they also only get 2% of global financing. So she stands as a living experience pillar of somebody who can switch career or add another layer to the career, approach it from an entrepreneurship example. But she is a woman, and she is a mother, and a fairly new mother at that. And, I was very happy to be able to support that. There's going to be a lot of mentorship. They've partnered with the Acumen Fund, which is Jacqueline Novogratz, who's, I don't know if I'm older than her or she's older than me. Each time we see each other, we call each other old friends.
You look like you're 23.
We call each other old friends. But it's nice to see that intergenerational knowledge being put together in one crucible and bringing out something new. And even though a lot of the innovation was to speak to women's health, 2 of the winners there were young men. And I love that, because it also means that we're equalizing, across, whether you want to call it the sexes or the genders, call it whatever you want to call it. But men are taking women's issues as seriously as we take our own issues. And I think that bodes very well for the future.
Wow, Her Excellency, there's so many things I want to talk to you about that you just started this beautiful way to begin this podcast and this conversation. But the first thing I was thinking about is, for those listening to this, if they have never heard about you, or which I would be like, I'm shocked, your loss, go Google. What would you want to share in terms of your story and your origin into this work? Because you're a champion for so many issues across the country of Nigeria and broadly, but you really are, to me, like a role model in so many ways, and I'm inspired to be in this conversation with you. But what would you share as your origin story for anyone listening to this who doesn't know you?
My origin story is probably a very unlikely one.
Ooh.
I was pregnant, I was expecting twins, I was also getting married, and really I thought I had it all. I had made my arrangements, I had my birth plan. I intended to give birth in the UK, where I largely lived at that time, but I was a Nigerian, and I feel very Nigerian. I feel very Nigerian, very African.
You look so beautiful.
I also feel very global. So, I think I'm your typical woman who probably had it all. And then when I encountered birth complications, which could happen to anyone, that was when I realized that we are all at the mercy of the health system wherever we happen to be. It truly is a lottery, but it shouldn't be a lottery. And I was probably in one of the best hospitals in my country, but I was still subject to a delay. And that delay cost the life of one child and left me fighting with the best my country had to offer, thank goodness. Otherwise, I might not even have made it. Fighting for my own life and the life of my child. And we're people of faith. So actually, when we run out of solutions, we tend to pray. And I always say, if a medic in Nigeria tells you to pray, you should really know that you're on your own. So when it became, God will not let this happen, and God will, I realized I had to do more actually than just pray. I did pray, but I started reaching out for help from all over the world. I was reaching out for tools. And it's a simple thing. For instance, you take breastfeeding for granted. You think it is natural, You deliver, and 3 days later your breasts become engorged. And if you've done immediate kangaroo mother care, and if the baby's latching on very well, you are able to breastfeed. But if you have a child who's a 28-weeker in an incubator, whose heart is not stable, and if you don't have a breast pump or a way to get your milk to your baby, then you realize it's not as natural as you thought it would be. And this is 1991. Wow. They didn't have breast pumps. I was very fortunate. My father tracked down a company somewhere on the Swiss-Austrian border.
Wow.
Who were making, in those days, the very first breast pumps. Put my brother on a plane, and then he had to drive through the mountains to go get one. Oh, and they didn't even sell them to individuals in those days. So there was a lot of diplomacy involved. This was, in those days, that was innovation. Wow. And my brother arrives back 2 days later, or Christmas Eve, with this very first rudimentary breast pump that weighed 45 kilograms. But it meant that I could express my breast milk, and it could be taken to the neonatal intensive care unit to be tube fed to my daughter. And that was 1991. But in 2021, that same company that made that rudimentary breast pump, I started a neonatal intensive care unit program with them in 3 states of Nigeria to empower NICU lactation. And it sounds very simple, but there's a whole science behind it. And a lot of that science is in managing the mother's emotions and making sure that even though her child is very ill, she can bond, because it's that bonding that brings the milk supply. I can't tell you how many gallons of neonatal intensive care unit breast milk we have pumped ever since. But I can tell you that in Nigeria, we have about 338,000 babies who are born prematurely every year. And if they don't get their own mother's breast milk, they run the risk of necrotizing enterocolitis if they're fed on artificial formula, which raises their prospects of death. So that's a program, for instance, that started because I remembered how difficult it was. And then I went to check the data. It can't only be me. I'm not unique. And when I saw in 2021 the data, I said, yes, even if it's 5 NICUs that build this body of practice that can then be carried across the country, it's worth it to me. So I always tell them, whether a program starts with my experience or the experience of another woman I have met, if we can learn from the experience of one and we can then take that to scale, it's worth the effort. There's another program I'm doing, a neonatal jaundice program, which is a whole state program in Lagos State. And we've equipped 16 healthcare facilities at all the tiers, primary, secondary, tertiary, with bilirubinometers, with cards that can tell you if a child has neonatal jaundice, and with phototherapy light boxes. It's called Project Oscar, Light for Life. And it's called Project Oscar because I met a young man called Oscar who had very, very severe cerebral palsy and kernicterus. And that was because when he had neonatal jaundice between day 3 and day 8, he's a British boy, he was born in Vietnam, it wasn't recognized that he had neonatal jaundice, so it wasn't treated. And he was left with lifelong neurodevelopmental injury. But he's also a very intelligent boy who told me his story. And then as soon as he told me his story, I realized that I had seen this before, and I had seen it a lot, but I never knew the cause. You know, in Nigeria, like many parts of Africa, if you have a condition within your family that you don't know where the help is, you tend to keep the condition within your family, and you don't necessarily seek for help. And I remembered that in 2006 on Children's Day, I had managed to secure a donation of 200 children's wheelchairs. This was when I was Kwara First Lady. And I remember my team saying to me, but Madame, you know, who are you going to give these wheelchairs to? And I said, well, I'll put the word out, and if anybody wants a wheelchair, they know they can come to me. And I put the word out. But that day, on the donation of the wheelchairs, I've never seen so many children come forward with their parents. They were bringing them in wheelbarrows, carrying them in their arms. And then I started to recognize children of families that I knew. But I had never known that these families had a child with special needs or a disabled child. So they only brought them out because I was bringing out the wheelchairs, and the wheelchairs were available. Maybe they had 6 children and only one was special needs, and we never knew they had one with special needs until this wheelchair donation I was doing, which was specially tailored children's wheelchairs. They were state of the art, actually. They were very nice. But I never knew the cause of the disability until I met Oscar, and I really talked to him in depth, and his parents. And they explained to me, in those days, they didn't used to do rooming in of a newborn baby. Oscar's almost 21 now. Anyway, we discovered that neonatal jaundice is almost normal. It's very common.
Yes.
It occurs between day 3 and day 8.
Yeah.
And you can only treat it between day 3 and day 8. So if you do not recognize it when it occurs and intervene in time to treat it, the children are left with lifelong injury. But the injuries don't come suddenly. They creep up on you. So it comes as the child is suddenly not feeding properly around day 7, suddenly very drowsy. And when you look at our cultures of a grandmother coming to bath for the baby, look after the baby, and then we name children on the 7th day. We don't name children on the day of birth in our culture.
Oh, wow.
We name children. It's full ceremony on the 7th day. So actually, normally on the 7th day, grandma's bath for the baby and dress the baby up. It's probably the first time mom is having a chance to dress up again. And, she's getting ready for this ceremony. And then they hand the baby to her. So if the baby sleeps all day on day 7, you're not really that alert on day 7 to notice. And then if the baby's eyes are rolling backwards on day 8, culturally you might think somebody brought a bad eye to look at your child. It wouldn't occur to you that you didn't see the signs of the bilirubin rising in the child getting drowsier and lassitude and lethargy. And so that program that we're doing is quite an unusual one, in that not only have we equipped the hospitals with the latest of equipment, we are also teaching the mothers the signs as part of their antenatal and postnatal. Of neonatal jaundice, we have little strip cards that you can press your baby's nose and look at the color. And it exists in a paper version. It also exists in a digital version.
Oh my God.
Which we're testing alongside each other. And then there's a serum bilirubin blood test to double check. And the first thing that occurred within 3 weeks of starting the program, it's the first time we're doing neonatal jaundice at a primary health level, because normally you would refer to a secondary or tertiary hospital to be treated in the Nigerian setting. But I was pleasantly happy when my M&Es brought back supposedly a challenge from the field. And I said, what's the challenge? And they said, there's this particular hospital, Alimosho General Hospital. It's one of the largest local governments in Nigeria. And they're complaining that the phototherapy machines that we gave them, the 2 is not going to be enough, that they're going to need a lot more. And I said, why is that? They're groaning under the strain of the referrals from the primary healthcare centers clustered around them. All of a sudden, they don't understand why all these children are having neonatal jaundice and being referred back to them. And I said, no, they've always had it. It's just that nobody was screening at the primary health level. And this is very important for children of color, because most of the guidelines and how to spot it, the research was done on white people. And it's very easy to spot in a white child or a lighter skinned child. But if you're dark skinned, you have to look for it elsewhere than the cheeks.
Yes.
You've got to press the nose and check. You've got to look at the palms, the tips of the fingers, the soles of the feet, and underneath the eye. And so that's why a lot of black children were going undetected. And we're doing this in the whole of Lagos, and we're hoping that the research findings from this will actually guide a new model. And really the policy shift I want is that every single child, wherever they're born in the world, be checked again for neonatal jaundice between day 3 and day 8 and get immediate treatment. If that can stop disability in its tracks emanating from neonatal jaundice, I think would have made a lot of families a lot happier.
Yeah, I mean, this is incredible to hear this story. And I remember when I delivered my son, I remember it's all standardized here in the U.S., right? They checked for jaundice. They checked twice over a couple of days of time, and they told me this is really important. At the time, I just thought it was like yellow eyes really is what indicated it. But I'm assuming now that that's probably when it gets bad, when it's like the worst case scenario. But some of these things that you're spotting, the symptoms, are so easy to go undetected. And this is what we're talking about when we talk about every pregnancy, and the work that your organization does and the work that our partners do, is that you are treating completely preventable complications and reasons that drive, whether that be lifelong disabilities or lifelong or end of mortality, right? So that was such a powerful story. Her Excellency, why is maternal mortality so high in Nigeria?
I think maternal mortality is high because our ratios of professional midwives to mothers are so disproportionate. Really, if you ask me the best way to bring a child into this world safely, it is for the mother to be attended by a professionally qualified midwife from the beginning of her pregnancy to the end. Our Mama Care program, which I started in 2015, started originally with just 4 midwives, which we employed directly in the foundation, and then we sent them to both public and private hospitals to give antenatal and postnatal classes. And this is a program I really actually had to insist on. I almost had to overbear the doctors in the foundation to say, no, I would like to deploy midwives. And I did this because at the time I was the global ambassador for the International Confederation of Midwives, and I had seen their midwifery services framework, and I had seen that a professional midwife can attend to a normal birth and can do much more than deliver the baby. She can also educate the mother in what to expect, during the pregnancy, to bring the mother through a demand generation, personal social health and economic education approach to that delivery bed in a better condition than she would have been if she just left the house and just came in an emergency. And I decided to invest in it, from the foundation, to invest in midwives and send them out. They became our ambassadors, delivering a continuum of care and counsel. And the first thing that occurred was we were noticing our Mama Care mums coming for 8 visits during their pregnancy, and not the 4 visits that at the time in 2015 was called focused antenatal care. So when they were bringing the data back to me and, should we stop them from coming? They like the classes so much. I said, no. If they want to come once a month instead of once every other month, please allow the mothers to come. And the other thing we noticed was that we didn't have deaths in our Mama Care mothers. So we could be working in a state where there were clusters of deaths in health facilities around us or in the communities, but we were not losing any of our Mama Care mothers. And so it started a bit of an anomaly. Is it because they're coming 8 times that they're not dying? Is it the increase in their knowledge that they're not dying? Is it the continuum of care? Now, whatever it is, probably still needs to be interrogated. But our Mama Care mums that have benefited from antenatal and postnatal visits and a personal social health and economic education approach during their pregnancy are staying alive.
Wow.
We are using tools, the same tools we use for our emergency obstetric and newborn care training for midwives and medics, the same tools we use for advanced obstetric surgical skills training for our registrars are the same tools that we are using, simulation tools, to teach women about their own bodies, the changes during pregnancy, how they should eat, and to listen to them. We don't just teach, we are also listening. We've backed that up with digital midwifery, so every class has a WhatsApp group, actually. And they keep growing. I think we have over 50 WhatsApp groups now, and the average membership of each group is about 500. So the women are also supporting themselves as peer support, as well as our qualified midwives being on the group to answer questions, to moderate, to refer. And it's working. I don't know if it's working because of strength of numbers. I'm actually beginning to invite very expert researchers to come and take a look at, why am I not losing mothers? Whereas around us in the country, mothers are still dying. But I think it's the meeting point of knowledge, self-care, professional care, and the time to listen so that you can intervene if a problem arises.
Right.
I personally, I love the program. It's very labor intensive. And now we're looking at AI tools to
tell
make
us a bit more about that.
Well, AI is very exciting. For instance, we ran ultrasound training for midwives in Nigeria. We did so with a partnership from General Electric. So how did it become a partnership to cover the whole country? It started with a donation of 8 portable ultrasound machines.
Wow.
So I took a vote from my midwives. I said, where would you like? General Electric is giving us these ultrasound machines. Where do you want to send them to? And my midwives spoke very strongly in favor of sending them to primary healthcare centers because those did not have ultrasound. And you would have thought that would be simple. My goodness, that is where the real program design started. So they nominated and voted amongst themselves, and we wrote to the primary healthcare centers saying, we've got portable ultrasound for you, which we wish to donate. And all of the primary healthcare centers were honest enough to tell us, we're terribly sorry. It's either we don't want to receive it because we don't have the electricity, or we don't have the biomedical engineer to maintain it. And this tells you really a lot about our system. Or we don't have a doctor who knows how to do ultrasound. So I said, well, it's not meant for doctors, because I was looking at it from a global point of view. It's meant for the community midwife to use. And oh my goodness, the protests became louder. Oh, we don't allow midwives to do ultrasound. I said, I beg your pardon? So in the end, we clustered into 3 states, approached the state governments, offered them training for midwives in ultrasound technology, ultrasound sonography. And that's when we discovered that it's the first time in Nigeria that midwives were going to be trained on ultrasound. And so from an initial target of wanting to train 15 midwives across 8 facilities, we actually trained 225 midwives as master sonographers across 3 states, because such was the demand. And we understood why the states were asking for such numbers, because there's often a rotation between healthcare facilities, and sometimes there's attrition. So a donation of 8 portable ultrasound machines became the training in an educational setting of 225 midwives in ultrasound. And it was so empowering just to watch them. I can send you the videos later.
Please do. Send them my way.
They all approached, the training rooms a little bit timidly in their uniform, sitting down. And then by the end of the 3-day trainings in each state, they sat the way I'm sitting, upright, and they were scanning the mums. But the part of that has led us to AI is because that sort of training always requires a lot of refresher training. And you need to also make sure that the person administering the ultrasound is reading the results right. So you can imagine us having now discovered AI-powered ultrasound, where we just have to teach them how to do the ultrasound, but the AI interprets the results.
Incredible.
And also stores those. So I came out of my meeting this morning super excited, and we're seeing it in other areas as well. In the past, running an EMONG program for an entire state would take 5 years and about £800,000. Now we're seeing digital EMONG, where yes, we're still going to do the physical training, but the retraining and the cascade can now be done digitally. So my last meeting of today is actually going to celebrate with a Danish foundation whose founder is a very close friend of mine, and we founded our foundations at the same time. We're both 20 years old, and she is bringing a digital version. It's called Safe Delivery App to Nigeria. So having run at our end, at the Wellbeing Foundation end, having run emergency obstetric and newborn care training, having run with our partners, Liverpool School of Tropical Medicine, advanced obstetric and surgical skills, I'm delighted that, that's one end of the paradigm. But at the other end of the paradigm, we can go to scale with new tools. And it's not either or for me.
Yes, exactly.
I think they are all pieces of the puzzle within health system strengthening. When I first brought EMONG to Nigeria in 2016, I remember, our social media monitoring was showing that some blogs were saying, why is she using dolls? But today in 2025, less than 10 years later, EMONG training has entered our national policy as part of the maternal mortality reduction index investments. And so for me, that's proof of the pudding. I might be an early investor in something, and I might be doing it from a charitable perspective, but it's not really charity. It's social impact, human development impact investing, where CSOs like myself can take that risk. Of course, we're not passing risk on to our communities. We check what we're using, we validate it, we get ethical approvals. But really, the target is if I'm doing something today, 2025, that's new, I'm hoping that in the coming years, whether months or years, I'm hoping my government will adopt it and take it to scale for the entire country. And there's loads more innovation out there.
This is incredible. And this actually leads us to the perfect next question, actually, where you just ended in terms of the government. I don't think people realize how big Nigeria is. And I really started to understand it more in Every Pregnancy's work, saying that we have massive states in Nigeria and they are almost their own countries all by themselves. And the government is a really key stakeholder in Nigeria compared to even, I think, other contexts. So when you say you want the government to adapt this across the country, what is the current relationship you think between civil society organizations and government? And how do you think the best way to work together actually looks like? Because we've seen with big funders, they want to come in, and I think a lot of funding gets poured into Nigeria. And I want to hear your thoughts on, do you think that the way that funding enters Nigeria and is implemented is actually the best way to do it? So that's sort of twofold question, is like, what is the model that you think works best to address the cultural and structural barriers that you had mentioned earlier?
Well, certainly when it comes to the health sector, we were what I would call early aligners with government.
I love that. Can I use that word? Yes, I'm an early aligner with Her Excellency Toyin.
We were very early aligners. I think it was in 2006 that I opened my first very small office in Abuja. And because I wanted to work with the Federal Ministry of Health on data, on health records, we established something. We were hosting the Federal Ministry of Health's partners, which were not many at the time, in what we called the Critical Core Committee. Of NGOs that wished to partner or supported the Federal Ministry of Health. So initially it was very simple support. They would be having an advocacy day and they would ask us all to chip in. But fast forward till today. Actually, don't let me fast forward till today. I would say the first time I really saw true impact come out of those alignments was probably 2012 to 2014, the Saving 1 Million Lives initiative. So we had all committed to Every Woman, Every Child of Secretary General Ban Ki-moon, which was the first time the private sector
stepped in,
was being brought to bear on the health challenges to help governments and help the rest of the world. And I think what was missing before in partnerships was you would have the NGOs that all have our models and we all think our models work. And you would have government which wants to receive our models but wants to receive it in their own way. And you might be doing all the work, but they wanted to maintain control. So it was always a slightly uncomfortable relationship, but we knew that to reach scale, we would have to partner with government. And then in 2011, Every Woman, Every Child came to Nigeria. And it brought with it the weight and the reach of the private sector into these age-old challenges. And that gave birth to Saving 1 Million Lives, which meant that government could set up a unit for high-impact strategic partnerships and push it to work in a way that government could also, I wouldn't call it control, I would call it stakeholdership and ownership and scale. And one of the very first successes of that was by putting lower zinc, low osmolarity, oral rehydration salts and zinc into the essential medicines list, which meant that if children had diarrhea, first of all, there was the advocacy piece that you don't treat diarrhea with antibiotics.
Yes.
You treat diarrhea with lower zinc. And that was the first big win for Nigeria. And I mean, even as far back as last year, I was still doing diarrhea programming in Sokoto State and in Kano State, high burden states. But that showed us what could be done if multi-sectoral partnerships were brought to bear on multilateral challenges. And today in Nigeria, we have the sector-wide approach. We have the MAMI. And we also have, from our point of view as global partners and local partners, we have the World Economic Forum's activators, which is really bringing all the partners together at, I don't want to call it a negotiating table, but what I will call it is, I think, was it you the other day who said collaboration?
Yes.
Yes, so we are collaborating.
Yeah.
We're making sure that investments are not only business savvy, but they're also doing good, and they're capable of sustainability and scale. I think long gone are the days where you want to do a program, and even though you brought it, you still want to be the one operating it 10 years later. What we all want to see now is that when we bring something, whether it's to a government or whether it's to a community, we want to see that government or that community's buy-in. And that buy-in is not always financial. It could be a financial buy-in like a counterpart, but it could be a buy-in in terms of data. It could be a buy-in in terms of program territory. We want to transfer the knowledge so that that knowledge stays within the community that we're bringing it to. We want to bring that community's research forward to be able to design better programming for system strengthening. And I hope I won't be working on diarrhea 5 years from now at the 2030 goal. I hope the communities would have been working on the diarrhea themselves so that I can go and start working on nuclear medicine.
Oh, interesting.
And molecular, because we do have partnerships at that level as well.
Amazing.
One partnership I'm looking at is using cell and gene therapy to treat cancers.
Wow.
And to see how we can bring the cost of that down, and to see if we can treat childhood cancers. I'm looking at work and measuring heat in schools. So I have schools-based programming in over 300 schools in Nigeria, and that is nurse-led programming. But as I'm beginning to look at the data of heat and illness, if I'm in the schools already, maybe that is where I should locate the heat measurements and be checking that the dehydration is not the cause of the proliferation of kidney disease. Almost every Nigerian hospital now, when you go to the nephrology ward, maybe you were expecting to see adults in the nephrology ward. All of a sudden, we're seeing children. And, I don't know the source of that. We need to know the source of it. The skin is the largest organ. Is there something being rubbed on these children's skin which, combined with the heat and dehydration, is giving them toxic levels? What is the cause of all this kidney and liver disease that we're seeing in children? So we have a lot more work to do, but we can't fully deep dive that intricate work until we've assured that the basics
are covered.
The basics are covered, and government is the duty bearer of the basics. So I see myself as somebody who tries to take an age-old challenge. I apply a solution to it. I apply the right human resources to it. I try and make it look easy, so that
you do. You make it look so easy.
But I try to make it look easy, so that those that may be scared of entering that terrain gain courage and come and enter the terrain. Because the problem of Nigeria, don't let me say the problem, the challenge of Nigeria that will rise the solution of Nigeria and the innovation of Nigeria, I can't do it alone. I need it to be replicated. I always share knowledge happily and widely, because I can't cover the whole country alone. And I'd love many, many more. I'm happy these days. I go out and I see young women and they say, "Oh, I'm doing this," and I say, "Great, come and join us."
I love that. And you having the perspective, Her Excellency, from government to funder in a lot of ways in philanthropy, because you also fund so many projects directly, and even the partnership across the world with different organizations, and then being an implementer yourself through your civil society work really gives you, I think, a full breadth of experience. So do you feel that the funding that's coming into Nigeria is best utilized in the system that it currently exists? Or do you believe that more of it should be going to local actors? You were at our panel earlier this week at Goals House, where Doris Malel from Tanzania was really uplifting and really hammering the point down that we need the money as local actors. No one understands the cultural context in which we're operating and the needs of the community more than those that are living and breathing this work every day and out with the community. What is your perspective on that?
I always respect communities. When I first started to work, I learned a lot from the late Maury Albertson, who ran Village Earth. And he always told me that the seeds of development of every community lie within that community. So you have to listen to that community. But I also feel that we need to leapfrog the local actors. If you want to help a local actor, sometimes the best help you can give them is after you look at their proposal, you accept what is in their proposal, but you add the best of global innovation to that proposal. And you train the local actor to be able to sit as an equal with the global partner and combine both sets of intelligence for scale. I think the urgency that we all have at the moment does support a drive for frontline globalization. So the local actor also must be raised to the level, so we have to empower the local actors while still bringing that global innovation to them. I think we need a new instrumentality that allows each to sit at the table without battling itself. And I think the current atmosphere is actually making sure that everybody can sit down. I think even the global actors have realized that if you have 100,000 and you have to use 57,000 out of it to rent an apartment and buy a small SUV for the person you're sending from global, you're better off finding a capable local actor. And then you too, as a global, you will state your standards that you want to see. And you allow the local actor to grow and deliver, and also empower them on the reporting. These are very exciting times, but we need to remember that what we're trying to do is not just save the life of the mother and the child, but also improve the prospects. As we say it, we say health for all, hunger for none, and we have to look at all those little layers in between, what we call the social determinants that will actually give us either success or failure.
So powerful. Oh my gosh, you just dropped the mic. We can't let it drop because we're actually recording the episode. But you are such a force, Her Excellency. For anyone listening to this and they say, I want to help, I want to get involved on any of the topics you discuss, but especially maternal newborn health, I want to help change the prospects for other moms and babies in Nigeria and outside of Nigeria, what is your best advice you'd give them to how to get started?
I would say go to the community. Study the community, listen to them, listen to women, and listen to the women that are looking after the women.
Exactly.
And then give. But one thing you can do, whenever I give, I also learn. So please give, listen, and learn. And then let's see how we can go to scale.
That's beautifully said. I have a couple of quick response questions for you to finish the sentence. And then we do have to wrap up, unfortunately. I could talk to you all day. I just want you to know that. And I feel like I'm going to just be calling you on WhatsApp and being like, Her Excellency, can you talk to me? I can't wait to be in Nigeria with you very, very soon. I'm excited for it. So every mother should be treated with
respect, dignity, and given the right supplies.
Every pregnancy should be
attended. Every pregnancy should be wanted. Every pregnancy should be expected. And every pregnancy should be catered for.
Oh my God, I got goosebumps. I got emotional hearing that. That was beautiful. I want to leave the world in 10 years looking like?
Gosh, I'd love to leave the world in 10 years looking like a beautifully shiny newborn baby that has everything he or she needed at birth, got the pinprick, and got the APGAR score with everything in place.
That's amazing. What I envision for my country, Nigeria, is?
What I envision for my country in Nigeria is a country where every citizen really has access to all the tools needed to look after themselves, to educate themselves, to bring the next generation into this world when they want it. And I have to tell you something, that people say family planning, and they think of family planning as just contraception. But as an African woman, I see family planning as both. I see family planning as contraception when I want to delay my pregnancy, and I also see family planning as conception when I want to have my family and grow my family. And I really hope the world will allow us to achieve that balance, to hold back when we want to, and then give us the help to go forward also when we want to.
So beautiful. One misconception about maternal newborn health that people have is?
One misconception is that it's easy. And really, bringing a child into this world is really one of the most complicated decisions that a family will ever make. And I hope everybody will be educated and empowered to be able to take that decision at the right time for them.
That's incredible. Her Excellency, any final thoughts on how people can support you and the work that you're doing at the Wellbeing Foundation?
To support me, please support me with research, with in-kind, with technical expertise, and with fiscal support too. The more we have, the greater the number that we can reach. And support us with your prayers also.
I love that. And I love that you bring the faith-based perspective on this. And that is such an important component to every pregnancy, as you know. And we are honored to announce that Her Excellency will be on the advisory board for Every Pregnancy. And we are so grateful for your leadership and your vision and even your insights here today. Thank you so much for being on our Born Into podcast. For all of our listeners, please support the excellent work, the innovative work, the creative work that Her Excellency's foundation is doing, the Wellbeing Foundation. We will leave links to how to support in the notes of this episode, but please continue to uplift this message and do what you can to ensure that moms and babies, whether it be in Nigeria or in Africa or around the world, are seen, are heard, and are supported in the right way with the most effective interventions by local leaders who know their community best and those who know how to support moms and babies in the best way and most inclusive way. Follow us at Every Pregnancy on social media. Continue to share these episodes with your friends and your networks, and really make this podcast one that is a resource for supporting moms, helping moms, and envisioning where every pregnancy in this world should be safe. Thank you so much for joining us today. And with that, we will tune out. And we appreciate you so much, Your Excellency.
Thank you so much, Isra, and well done, Every Pregnancy.
Thank you.